Hello.
Good evening, sir. One of your regular student has joined, sir.
Doctor, I am requesting all to rename yourselves. Please rename yourselves.
Dr. Baldev ji, good evening. Your regular student is there. Yeah.
Very nice, sir.
Just from academic work, jumping here to learn from you.
Yeah. I think what Shweta requested, all the participants, please keep your name on the screen. You can rename.
Your name will be soon very famous. Yeah, keep your name.
Yeah.
You will be flying high. Yeah.
The point is, at least we come to know individually to the person. I think by face, I may not be knowing everybody. And even I request all of you that keep your video also on. Vishal, are you ready?
Yes, sir.
Yes, Dr. Drija, Anjuman, Hetvi, please keep your video on. And I request others where only doctor is seen, so you can rename and put your name, please. Vishal, I think, okay.
What is the latest news from your daughter here? Enjoying?
Because, Shweta has know all the details of every person. That's why she is not able to manage. Anyway, good evening, friends. Welcome to this Iap Tuesday Pg Clinic. Today, Dr. Vishal from GCS Medical College is the presenter. And I request all the students and even others on the screen, as I said, that keep your video on and rename yourself so that we know each other and we can have the good interactions. In the patient also, what we say, that call by the name. So that's very important. I think that is the first lesson which we'll have to keep in mind, that if I know the name, I can interact with the name of the person. And that I would say give the good feelings to both of us, to me and to you also. So please, for that purpose. And those who are on even the attendees link that put your questions, queries, please act very fast. make it, I will say, very live discussion. Even put your questions, even create the controversies, contradict your friend, and try to discuss, I will say, the very specific point at length so that there will be more clarity, less of the confusions, and that will help on the long way, not only the exam, but I will say in the practice also. Anyway, Vishal has already started sharing the screen. So, okay, Vishal, you can share your screen and start this history part.
Good evening, everyone. Informant being mother of a 45 months old female Hindu by religion, born of non-consanguineous marriage, residing at Lunawada, Gujarat, belonging to lower socio-economic class as per modified Kupaswamy scale, presented with chief complaints of fever since 1.5 months, abdominal distension.
Vishal, there is some problem with your net.
7 కుదదా ఉండొచ్చు వంట మనిషి ఏమో టీ పెట్టేసి అదే అంటే నేను ఇంతకు ముందు పోదాం అనుకున్నా కొంచెం ఈవినింగ్ అయితే
I request others, those who are not speaking, please keep your audio off, keep yourself muted so that no disturbances. Vishal, there is some network issue on your side.
Yes. Yes, sir.
I think, okay, you can start it.
Fever since last 1.5 months, 1 to 2 spikes per day, intermittent in nature, non-documented. The fever was documented to be 102.7 degrees Fahrenheit in hospital, which was high grade, not associated with chills and rigors, relieved by taking some oral medication. Child is active during interfebrile period. Abdominal distension since last 1 month, insidious in onset, gradually increasing size, first seen in upper part of abdomen on right side and associated with lot of appetite and not associated with constipation. Weight loss since last 1 month according to mother, gradual in onset, associated with decreased oral intake and decreased normal daily routine activities of the child. It was noticed by the mother that the cultural threads tied to the child were becoming loose. Vomiting since last 7 days, 3 to 4 episodes per day, non-bilious, non-projectile, not associated with food intake, containing food particles and water, not containing blood, mucus or worms.
I think, Vishal, can you stop sharing over here? Because whatever the information he has provided, let us try to focus. He has become very precise, 45 months. So almost, I will say, comes to around 4 years. Some months are there to complete the 4 years. For the sake of discussion, you may take 4 years for easy understanding. He said, let us take one by one the symptom and try to understand. Then we'll all the symptoms to put together. And then again, we'll try to that. What is the likely issue with the child? He says that fever of 1.5 months. I think very nicely he has given the details. That fever was initially low grade, then gradually increasing. And even in the hospital, it was recorded more than some 102 degree Fahrenheit. I think having this long fever, what common conditions will come to your mind? I think 1.5 months, that is almost 6 weeks. Forget regarding all other details. We'll go one by one. Just suppose if you are thinking for fever, which is as documented, because he has provided information, and that is since almost 6 weeks. Then which type of the conditions will be presenting with this type of prolonged fever? Anybody? I wish that please participate voluntarily.
As we are taking, I wanted to a little detail about fever.
Yeah.
How long the child was kept in the local place and when the child was taken to the hospital. Initial this thing and response to before
Yeah.
the other symptoms started. A little more detail may be important about the fever. You just mentioned the duration and also the degree, but how it was handled initially by the local doctor or this thing, and when they took and when they it got referred to this thing. That information may be relevant before the second symptom started. Do you think I'm valid or my this thing is?
Yes, sir. Vishal, you have any information regarding the fever?
Sir, it is mentioned in for current illness. It is present in subsequent slides, sir.
No. The point is
Yes, sir.
regarding the fever for 1.5 months, hospitalized.
Yes, sir.
What was the interval between that and what treatment or something was done by some other practitioner or consultants?
The child was taken to some general physicians and it was treated symptomatically by oral medication, sir.
Okay, it
The
was
child
treated
not
by
all-
family doctor only, no pediatrician
No, sir.
for 1.5 months.
Yes, sir. No pediatrician, sir.
Okay,
General physician, general practitioner, sir.
okay. Then I think directly came to Lonavala Hospital
Yes, sir.
after 6 weeks.
Yes, sir.
Okay, I think whatever the information we have, we can go further. Anybody? I want that voluntary, please take the symptom one by one. Whatever, simple, very simple question. You are sitting in the OPD and fever of 6 months. And what he said that the documented fever, initially low grade, then gradually increasing. Somehow for parents were probably from remote place. So some family doctor or general practitioner treated with some oral medicines, which Dr. Vishal has no details. But fever persisted in short. And in then this type of situation, simple question that which conditions may come to your mind when the fever is of longer duration of 6 weeks? Anybody? Common conditions. Then we'll go to the next symptom, then third, and then try to put all together. Again, I will wait for some time, but I wish that the voluntary participation should start.
So tuberculosis.
Okay, Hetvi. Okay, one is tuberculosis, common in our country, will come to your mind. Anything else beyond tuberculosis? What other
Typhoid
reason?
fever, sir.
Okay, enteric fever can also come in this way, agreed. Enteric can come, tuberculosis can come, anything else?
The brucellosis.
Yes, brucellosis, very good. Janmijay, you can rename yourself on your laptop.
Yes.
I hope you know how to do it. But his point is valid. That yes, if you are considering infections, brucellosis, yes, we do come across. Anything else beyond that? So if you are taking infection, then first take the infections. The enteric fever, tuberculosis, brucellosis, anything else? Any other infection? Come on.
The parasitic infection.
What parasitological?
So, nighttime fever common in filariasis.
Come to the common. Yes, I think filariasis is also should be kept in mind. I think Janmijay must have seen the patient of filariasis in the past. Janmijay, have you seen the patient of filariasis?
Sir, in UG pediatric in clinical work hospital.
But you have seen the patient.
Yes, sir.
Yeah, because I noted that after some discussion, filariasis comes to his mind, and that indicates that either he has read somewhere or. But the point is good. Not, I will say common, but you can keep in mind. Of course, agree. Any other reason? Any other reason? Come on, I will say some in the exam somebody is asking, you should not waste your time because that is the waste of your time. Exam is not losing the time. So you should be very prompt. 6
Sir,
weeks. Yes, Sagrika?
occult infections like liver abscess,
Very
septic
good.
arthritis.
Very good. I think keep in mind your abscess is anywhere. Maybe the liver abscess, maybe the subdiaphragmatic, not so common in pediatric, but the pelvic abscess, or anywhere even the abscess can present in this way, which we have missed to note it. Yes, Sagrika, what next you say?
Sir, inflammatory diseases like Kawasaki.
Okay, I think she is coming to the next group, that the non-infective inflammatory. But any infective which is not bacterial, but some viral can also come with the prolonged fever. And then we'll go to the non-infective inflammatory. Agree. Any condition comes to your mind, which is not the bacterial, but viral. Usually viral subside within 5 to 7 days. But any viral which can present with a prolonged fever for 3 weeks, 4 weeks, beyond that. Yeah, CBV, very good. Abstinent by virus can present in this way. And common even, I would say not uncommon nowadays. Anything else?
HIV, sir.
HIV, very good. Keep in mind HIV. Okay, anything else? Even don't forget the common infections, malaria, even urinary tract infection, because sometimes they may not have the very specific symptoms and commonly missed and may present with the problems and complex. So keep in mind the common conditions first, common infections, malaria, urinary tract infection, anthrax. I think very good responses from all the students, tuberculosis, brucellosis, right? Even these abstinent by virus, HIV, abscesses. But now as Sagrika was taking the next group, it may be non-infective, and which non-infective conditions may present with a prolonged fever. Sagrika, you can start it.
Sir, Kawasaki disease.
Okay, Kawasaki. Of course, Kawasaki is common and we do come across. Any other condition?
SLE.
The connectivous SLE in the female child, but what is the age for the SLE, Hetvi? Common age?
Adolescence, sir.
Yeah, usually older and females. That's good. But it can be that we should keep it. Or even the juvenile idiopathic arthritis, that can also present. Any other third group?
Malignancy, sir.
Malignancy, very good. From where I got the response. Sorry, I could not locate the person.
Drija here, sir.
Sorry?
Drija here, sir.
Okay,
Drija.
Drija, yes. You have kept your video off, that's why. Yeah, but I was trying to look. Okay, you are seen now. So, malignancy, yes, leukemia, I1, or any other malignancy can also present. Lymphoma can also present. So, what I mean to say that when only fever of long duration, all these conditions will come to our mind. Now, let us go to the next condition. Next, I will say symptom. And then we'll be having the next symptom here said abdominal distension. That is also since 1 month. Vishal, for the recollection of all of us, can you just describe in short without sharing what was the details of the distension of abdomen? Just characteristics, how it started, how it was progressive.
Sir, it was gradually increasing in size. First seen in upper part of the abdomen on right side, and it was not associated. It was associated.
Okay, I think we have discussed in the past also several times. For the recapitulation, let us start. Number 1, when you will say it is a distension of abdomen.
Would not associated with constipation, sir.
Yes. Okay. Let us start from this basic question. When you will say the distension of abdomen is there any point to say? Because just parents may otherwise also complain, and there may not be.
Sir, it is.
Is there any criteria?
Local.
Yes, Sagrika?
Sir, is it a local or diffuse, single or multiple?
Sagrika, before that, I want to say that how will you say that yes, it is distension? Sometimes parents may complain, but may not be distension. How you will convince to yourself or even to your examiner that yes, this is distension? Is there any criteria from any point you can say?
Sir,
Yes,
sir, we have to examine the patient from the foot end.
right? Monica?
Sir, for checking the distension of abdomen, we have to examine from the foot end, and we have checked the level of abdomen at the level of nipple, sir.
At the level of
Nipple, sir.
nipple, okay? And a chest. What is
Chest.
the point that usually abdomen, except in obesity, obesity is a different story. Otherwise, in a normal child, even adults, the abdomen is usually below the level of the chest or at the level of chest. If the abdomen is above the level of chest, you can say definitely it is distension, which may be one simple reason, maybe due to some serious condition. But yes, it's still distension. So keep in mind simple points. Then the next question, Sagrika, now how will you take? Suppose if it is distension.
Sir, localized or diffuse.
Right.
If it is localized in which part of the abdomen, and single
Suppose,
or
sorry to interrupt you. Suppose here Vishal has informed us that it was on the right side. At the beginning, it was on the right side. Then what does it indicate?
sir, it might involve the liver, hepatomegaly.
Yeah, it was right upper even. He said specified. So right upper part of the abdomen. I think very simply you can take that it indicates the organomegaly. Right side more likely hepatomegaly. Can it be with the left side, suppose splenomegaly?
It can be both hepatomegaly also and splenomegaly.
Just for a clarification, please keep in mind, at the beginning, spleen presents as a lump, as a mass, may not be the distension. But if you examine, if you palpate, yes, some lump is there. But when the spleen is enlarging and very huge one, then of course it will contribute for the distension of abdomen and the left hypochondrium also. Just for the clarification. Okay, Sagrika, take it further.
If the swelling or abdomen distension subsides on when the patient sleeps, or is it disappear at any time of the day or not?
Okay, Vishal.
No, sir.
Okay, suppose if it is there, Sagrika, what does it indicate?
Sir, there can be any hernia defect which can be subside on lying down.
Okay.
If the abdomen is just distended just after feeding, it is normal in infant
But
age.
you know that the hernia will present the hernial sites, hernial orifices. Second thing, it will be separate mass, I will say swelling, rather than mass swelling at the hernial orifice. But may not be the distension of abdomen unless it goes for some problem or complication, right? That obstructive hernia. Then probably it may go for. Okay. Any other reason for distension of abdomen? How will you take it? Any other person? Richa, how will you take it?
Sir, there could be 5 causes, either fluid, cystis,
Okay,
organomegaly,
right.
fetus is not there in the
Yeah.
pediatrics,
Okay,
and the flatus.
okay. Suppose if I directly ask you, how will you qualify this distension of abdomen due to constipation? That means what will the characteristic you will get in the history from which you can suspect that this distension of abdomen likely due to the constipation.
Sir, fecalith is palpable.
Okay, any history, Hetvi. Then you go for examination. But on history point,
No, not passing of stool.
Stool not found.
stool has not passed or some
Okay.
straining
History
while
of not
passing
passing
the
the stool or constipation. Okay.
or
Any sense?
straining while passing the stool.
I think I want this very specific points pertaining to the distension of abdomen. Anybody? Chandrajay? Nirali, you can also participate. I think that is good that you can say later on that from day one of my residency I was discussing. That is always good. Anybody? You know, I want your specific, I'm sure it must be there in your mind. I want to remind you. In constipation, whatever the history you will get, what the parents will be describing, when you are asking for the progress. Any specific point on progress? You know, in the constipation, there will be waxing and waning. Once the child has not passed the stool, there will be the distension. But after passing the stool, distension may decrease or even may disappear. That is very characteristic, waxing and waning. Hardly in some other conditions you are going to get it. And of course, what Hetvi says that on palpation, you may feel even the fecoling. How will you decide that this is the fecal matter and nothing else? That is also good on palpation. How you can convince yourself that this is likely the fecal matter?
Sir, localized area involvement.
Yeah, where localized commonly?
Mostly, sir, rectosigmoidal junction.
That is far away. Most of the times, you know that constipation due to chronic constipation is due to the colonic conditions. Suppose if you take the classical example of Hirschsprung disease. You know, on the contrary, left side, left iliac fossa, if you get very specifically, I think that is more favoring. And when you are trying to palpate that mass with your fingers, even indentation is possible. You know, because ultimately fecal matter is the soft matter. Other mass you cannot even compress. But here it may be possible, here unless it is very hard. So from the simple points you can decide that what is the likely cause for the distension of abdomen. Okay, suppose directly if I ask the question, Sagrika, that what will be the characteristic or how will you qualify from the history that this is favoring the ascites?
Transversely stretched umbilicus.
Okay, from the history that after this inspection you will come to know.
It starts from a fullness of the flank.
Yeah, that's very important. How it started, always, you know, when the huge ascites, the huge abdomen is distended, you don't know. But once you ask the parents that how it started, at the beginning where this distension was seen, then probably they may complain that fullness of these flanks. Later on, gradually with the progressive, it goes from lateral to medial. It starts from lateral, gradually with the progress of ascites, it goes to medial. But suppose, Sagrika, it goes from medial to lateral. The distension is increasing from lateral to medial. Then what it could be? That means distension started from middle part and then distension increasing to lateral and then huge distension of the abdomen develop.
Intestinal obstruction.
The ascites, what he said, it starts from periphery. And then gradually as the ascites develops, fluid is collected, it maximum distension goes to the medial aspect. But suppose in some other patient, the mother says, parents say, that distension started from the central part, middle part, medial. And then gradually distension was increasing to periphery, laterally. What it could be?
Intestinal obstruction.
Very good, very good. That is suggesting intestinal obstruction. Because internal obstruction mainly it starts with the umbilical region, and with gradually more progress of the obstruction, it goes toward the periphery. This is just to sensitize you that take this distension of abdomen in details. Sometimes simple in the infant's protuberance of abdomen can be without any reason or simple reasons. That is in a case of even the infants up to 6 months, even without any reason, laxity of the abdominal wall. Maybe even and are there any other pathological conditions with the protuberance of abdomen?
Hypothyroidism, Down syndrome.
Very good. Hypothyroidism, Down syndrome. Anything else?
Cushing syndrome.
Okay, in the Cushing, it is something different. Vishal.
Visceral fat.
But MPS, yes, mucopolysaccharidosis. So these conditions, even the hypothyroidism, the most common. Down syndrome, yes. Even rickets can present. Keep in mind, rickets can present. Okay, so I think now coming back to our patient, what he has, Vishal has described, let us try to focus. And the third point, then we'll go for all the points together. He has said the weight loss. Janmeja, how will you define the weight loss? I think here parents are complaining, it's all right. But suppose if you have some more details information, how will you define exactly the weight loss? Any idea? Monica, how do you define the weight loss? Because now everything should be very precise. Just I will share impression, if you say, may not be the correct impression. We should go for some objective phenomena which you can say at least that yes, it is there. Sagrika, any idea weight loss, how it is to be defined?
More than 5% weight loss, sir, in last 3 months.
Okay.
With a normal diet.
One
Falling
more point.
the percentile line on the growth chart.
Yes. Sorry,
Avoid
Sagrika. What did you
understanding,
say?
Falling the percentile line on the growth chart.
Yeah.
I
I think Sagrika, that is different. That is for assessment of its growth. Then or assessment of nutrition. But for the weight loss, what Vishal said, please remember, loss of the weight more than 5% in the last 3 months with maximum record. Vishal, that you should remember. Whatever the maximum record in the last 3 months. And now weight, if it is more than 5% lost, it's weight loss. Here consider that the weight loss was there, whatever he had described. Right. Now, what the vomiting. What does it indicate, the vomiting? Vomiting also, I think, is a non-bilious. So what does it indicate? Or other way, now put all the symptoms together. That 4-year-old girl has come to us.
Yes, I used my engineering knowledge and
with fever which is documented of 1.5 months or 6 weeks.
Okay.
Distension of abdomen, he said 1 month. Weight loss is there according to parents. And now the vomiting. If you put all the symptoms together, what will be your first impression? That what problem is developing to the child? Yeah, any idea? I think try to link all the symptoms one by one. Try to link the
There can be
symptoms.
liver abscess.
Yes.
Sir, it can be liver abscess or any liver pathology.
Okay. Why, Sagrika? How you are suspecting? What is your, I will say, explanation for liver abscess?
Sir, there is a fever and abdominal distension and vomiting. All these three can be there in liver pathology, and associated weight loss can be due to any synthetic abnormality of liver.
Okay, I think idea is good. That fever at least indicates documented 102. That means at least inflammation is going on, whether it is infection or non-infective condition. Now, related to the distension of abdomen, probably it should be somewhere in the abdomen. GI tract problem. We can take it this way. And with this, even the weight loss may be the part of infection. Right. Vomiting again may be the part of toxemia. And if you are thinking for the liver abscess, okay. It's not, I will say, wrong. Right, good thought. Anything else? Further.
Sir, enteric fever.
Okay, enteric fever. Help me explain the enteric fever.
Sir, in enteric fever, if complicated enteric fever, it can be presented with ascites.
Okay. Ascites due to what? What complication? What I mean to say, in a case of enteric, what complication will lead to the ascites?
Hepatitis.
Okay. Hepatitis can lead to this problem of ascites. Okay, that is good thought. Any other reason for the distension of abdomen in a complicated enteric fever? It's a complication of enteric, but there is no ascites or no liver involvement. Some other complication which is more common.
Ileus.
Fortunately now with the good antibiotics, it is not so common. Yes, it will.
Sir, ileus.
Yeah. What is ileus?
So paralytic ileus.
Paralytic ileus due to what? Paralytic ileus due to what? In a case of enteric, we are discussing.
Yes, sir.
Toxemia, sir.
Toxemia, very good. You know, toxic paralytic ileus is known. As in any septicemia when it develops. So toxic paralytic ileus and enteric with the presentation of the distension of abdomen or 4 to 6 weeks not properly treated enteric can present, yes. It can go with the liver involvement and even the ascites, yes, as Sagrika was describing. So I think liver abscess can remain one of the possibilities. Enteric is remaining as the second possibilities. Any third possibility? Any third possibility? Anything else? Please come on. Any other possibility further? Common, I will say common chronic infection. Which one you should consider?
Tuberculosis.
Yes, tuberculosis remains one of the possibilities. And then in tuberculosis, what is the cause for distension of abdomen? Suppose if we consider tuberculosis, fever, yes, weight loss, yes, we can explain. But then what does causes distension of abdomen if it is tuberculosis etiology?
Lymph nodes.
Extrapulmonary tuberculosis.
Sorry, Sagrika.
Sir, extrapulmonary tuberculosis.
Okay, which extrapulmonary?
Lymph nodes.
Abdominal, sir.
Was abdominal. Then which abdominal pathology?
So
Abdominal
multiple lymph node enlargement.
Sorry?
Multiple lymph node enlargement.
Okay, how this multiple lymph node enlargement will present as a distension?
No, sir.
Then we are talking with a distension. We are considering tuberculosis because fever is there of 6 weeks, because weight loss is there. Agreed. But then we are trying to explain that what is the cause for the distension of abdomen due to tuberculosis. Yes, I think I could see Dr. Deepa Firke. Madam, are you there?
Yes, sir, I'm there.
Oh, very nice of you. I could not locate you earlier.
Yes, sir, I'm hearing. I'm a student here.
No, madam. I wish that please, even you can participate, you can ask the questions to ourselves, we can put your comments, questions even, because ultimately we wish this interactive session. Dr. Deepa Firke is the faculty of pediatrics from, I think, Dr. Miraj. Am I right, madam?
Yes, sir. Yes.
And she's very good clinician and teacher. So I'm sure that her presence will also make difference in our discussion. Anyway, who will take it further? That suppose if you consider tuberculosis, the distension of abdomen due to what? Or what are the various regions first? And then try to consider it our patient. The tuberculosis and distension of abdomen. Janmejay?
Sir, hypoproteinemia.
Sorry, somehow your voice is not clear.
Sir, hypoproteinemia.
Okay, hypoproteinemia due to what? In tuberculosis, why there is hypoproteinemia? But somebody has put in other way, ascites. Okay, I think, can you come on the screen, please, because you are able to put on the chat box. Ascites as tuberculosis, whether ascites is known, Sagrika?
Yes, sir.
That is due to what then? How the ascites develops in tuberculosis? What is the mechanism? We'll have to explain. Any idea? Anybody?
Exudative.
Exudative, yes. A3. How exudative means? Fluid is exudative.
Yes, sir.
Okay. Which structure is involved in a case of ascites due to tuberculosis? Which structure of the abdomen is involved?
Lymphatics.
Anything else? Which abdominal structure I am talking?
Pierce spaces.
Yes, Chanmejay?
Pierce spaces.
Okay. But ultimately, with Pierce patches and everything involvement, ultimately, which structure is involved in abdomen, which is responsible for ascites? We want to take the lead to development of ascites. Please remember.
Peritoneum.
Yes, Rija?
Peritoneum.
Peritoneum, good. Then how the peritoneum is involved and that peritoneal pathology in tuberculosis, how they present? What are the various presentations of tuberculous peritonitis? Let us ask the question in this way. I hope that you remember your undergraduate days, MBBS pathology teaching. You know, it can be, one is the exudative and second is hyperplastic. You know, growth of the tissues can also present. Anyway, I think ascites is one of the presentations of tuberculosis and which can present the distension of abdomen. Any other reason for or a variety of pathology with presenting with the tuberculosis with this distension of abdomen in a case of tuberculosis? Any other pathology? One is ascites. Agreed. Suppose it
Liver
is,
involvement is common in congenital TB.
sorry, Trija.
Liver involvement is common in congenital TB,
Okay,
tuberculosis.
not in acquired tuberculosis, it is not congenital. In acquired also, whether the hepatomegaly is known.
Yes,
Yeah,
liver involvement.
even hepatosplenomegaly, RE system organs, maybe the hepatosplenomegaly, maybe only hepatomegaly, maybe due to ascites. And suppose it is the problem is the ileocecal region, then how they presents abdominal tuberculosis. You must be knowing that I think surgery also we were taught.
Mimics appendicitis.
Why the appendicitis? It is not the acute condition. Ileocecal tuberculosis. As somebody has put very right, intestinal obstruction. I think ileocecal tuberculosis is not uncommon, and that is the hyperplastic variety. And that presents with the intestinal obstruction. That can also present with the distension of abdomen. I think now we have the varieties of explanations for distension of abdomen due to tuberculosis. Maybe hepatosplenomegaly only, and may present with the distension of abdomen or upper part of abdomen. May present with some mass-like structure and intestinal obstruction and mass-like structure in right iliac fossa, that means ileocecal variety with the intestinal obstruction. Maybe even these ascites. Of course, even may not be palpable or another problem, but it's mesenteric lymphadenopathy is also part of presentation of abdominal tuberculosis. So now so many things we have got. Now my question, I think what Janmejay mentioned, that Pear's patch is another thing that I think that's the basic pathology. And it can cause even ulceration also, tuberculosis ulceration. I think we must have taught in pathology in the second MBBS. Can it present with the perforation? Tuberculosis ulceration, whether can it present with the perforation? Who will answer? Fortunately, nowadays, with the better drugs and early understanding of the disease and treatment, we don't get this complication, but as the students we used to get, even as a junior AP, I have seen the patients. And I'm sure Srinivasan sir and even Dr. Deepa will agree that not so common. The only thing, the perforation, intestinal perforation, more common with the enteric, less common with the tuberculosis. But occasionally, yes, tuberculosis ulcer can also present with the perforation. And that will be present with the peritonitis, which is serious condition. And even the tuberculosis peritonitis is known as, already we discussed with the ascites. So I think so much so we discuss. And with this reference, I'm sure that you are going to get the case of malnutrition in MD examination. And suppose in a case of Kwashiorkor, patient is there or somebody may ask you, what is the cause of the ascites in a case of Kwashiorkor?
Protein deficiency, sir.
Okay, we said protein deficiency because naturally Kwashiorkor is the disease with the protein deficiency, right? But I don't agree. That's the problem. This is most common answer in the exam. And that's why commonly examiner are asking.
Sir,
But the reason is something different. Yes, Sagrika?
there is a pathology in the sodium potassium pump, and there is a more sodium in the body, and so there is a fluid retention. So that is why.
Yeah, that is the cause for I will say pathophysiology for edema. Agree. But that same pathology is not responsible for ascites in Kwashiorkor. I think with some of our discussion which is going on, and with the reference to that discussion, I asked the question. So I think you should get a hint. It is tuberculosis. It is said in these, I will say, old books, McLaren and Jelliffe and all others, they have mentioned very nicely that in the case of Kwashiorkor, if you get the ascites, it is tuberculosis unless proved otherwise. Srinivasan sir, I think, do you agree with me, sir?
Agree. How can I am?
No, sir.
Your
Because-
detailed entering of each and every symptom is, yeah. I am
Right.
mesmerized with your patience and the
Thank
way you are
sir.
encouraging students to come out. No, what? That's good.
Because, sir, gradually I'm understanding that unless we know for all these,
No, yeah, very
clarity
important.
of these
Symptom
concepts.
analysis is very important.
just we reach some diagnosis, I think may not be, but how we reach the diagnosis?
Yeah, symptom analysis. They have written book on symptom analysis.
So
It's very important
please,
that they have
keep
to
in
know.
mind. Yeah. Please keep in mind, and I'm sure that I'm not sure whether how much now we are reading this McLaren, which is a textbook on nutrition, and even the Jelliffe, who has written the book on tropical pediatrics. Let me, I will say, speak a word for Jelliffe. Dr. Jelliffe was from UK. He used to learn these tropical diseases. And what was his, I will say, methods of learning? I'm sure that to all the students and to all of us, Sagrika, it was inspiring how he was learning the tropical disease. He used to go to the country where the disease is there. He will work there for 6 months or 1 year. He will work like this intern or the junior person. And then he will write the book on that topic, what he has seen. That was his methods of learning. And I would say it was really marvelous book during those days which we are reading, the tropical diseases by Jelliffe. That book was there. And one of our examiners, I remember what she asked the question, views of Dr. Jelliffe on these tropical diseases. That was the full question in the examination. His views were very difficult. And these people have coined these very important, I will say, some of the things which we could not do in our own country where problems are more. But they derive this information. And that's why I think very important to remember that in a case of Kwashiorkor, fortunately now, we don't get the much more, I will say, condition, I would say patients with the Kwashiorkor condition itself. But if at all, at least we should know the reason. Anyway, suppose this patient has no fever. This patient has no fever. Gradually distension of abdomen. Progressive, slowly progressive, and now the huge distension of abdomen. And there is severe anemia. What condition you will keep in mind? No fever. Fever is not there.
Hemoglobinopathies like thalassemia, sickle cell anemia.
Okay. But Sagrika, 4 years old child never requires the transfusion. And liver is enlarged, but the spleen is not enlarged. And mother will say even that the distension gradually started after the age of 1 year or 2 years, not initially, and never required the transfusion. Main problem of the distension of abdomen. And even this weight loss is also significant. Or otherwise, mother will say child is not gaining the weight.
Sir, celiac disease.
Very good. Keep in mind the celiac disease also. Or sometimes celiac disease with some infection may present in this way also. In our country, it is not uncommon that celiac disease is going on and the same child develop the enteric. And then may present in this way. Even it may happen that you will treat the enteric. Patient may improve from the infection or fever point of view, but distension persists. And later on you come to know that, oh, this is patient is having the celiac disease also. I remember long back we had one patient. Nobody was knowing celiac. Blood culture was positive for the enteric, so naturally our focus was on the enteric. But even after months together, patient had persistent distension of abdomen. Even weight was also a problem. And came to know that, yes, it is celiac disease also. So keep in mind, I think as a clinician, so many things will present in this way. I think already we spent 1 hour. And only 2 slides Vishal has presented. Only symptoms. Why actually I want your attention? But this is the really beauty of the history. Once you understand, probably this will not take this much time, but for understanding definitely, if you have the clarity of the subject, it makes difference. And so many conditions. Now we don't know exactly that which condition has presented to us. But here we have this, all the thoughts, ideas, analysis, then probably we'll be able to reach even an uncommon condition. Vishal, I think you can take it further. On the 3rd slide.
For current illness, the patient was taken to general physician and was given some oral medications for fever. According to relatives, only one medicine was given for fever. No other medications or any oral antibiotics were given. The patient...
sorry to interrupt you. But I think we should find out this medical person and we should appreciate him. Sagrika, I'm sure that all of you will agree with me that this practitioner, according to
I fully agree with you, sir.
Sir,
They are all rare people. That's no?
Yes, sir. I think even pediatrician may not be available or any consultant. Where he has given, according to Vishal, only one medicine, that is the fever, for the fever, and even no any oral antibiotics. And I'm sure Vishal has put on the paper, so he must have confirmed. And really, if the practitioner is practicing this way, I think we should have. And that, Vishal is discussing the case from Lunawada. All of us know it's a very small place in Gujarat. And that to the patient is away from Lunawada. So must be from small village. And that practitioner must be practicing at small village. I think we should locate him. And such persons, definitely, that's good. We have to appreciate people also. This is also learning for all of us. Not only, I will say, we are teaching them. They are also teaching us. That is good even. Okay, please take it further.
The patient was consulting the same doctor for fever, but was not admitted and no investigations were sent. Then the patient was consulted to General Hospital Lunawada and got admitted here.
Okay.
Negative history. There was no history of rash.
Small request, Vishal. Whatever the negative history you mentioned,
yes, sir.
Just one line explanation. What was the idea?
Sir, rash for in case of to rule out viral infection, dengue, like dengue fever. No history of jaundice to rule out any.
I think one point. Some of the patient was having the fever and rash even before 1.5 months. That subsided. And now this story has started of fever, distension of abdomen, the whole thing which we discussed. But the history was there for fever and rash before this illness. How will you correlate? Maybe in some other patient, suppose if it is there. Sagrika, any idea?
Sir, there can be rheumatic fever.
Child is only 4 years old and rheumatic is 5 to 15. Right. And here very classically I am telling, unfortunately this child was not vaccinated. And this child was having the fever with rash which remain for 7 to 10 days. Then the patient recovered partially, but later on the problem again started with the fever, distension of abdomen, even this vomiting, the whole thing story which we discussed. But the only point if I add that there was history of rash and fever, few days or few weeks before this illness, how you will link that fever with rash and this present etiology. In other way, which infection can aggravate or precipitate tuberculosis? Suppose if you are considering tuberculosis.
Measles.
Measles, very good point. So, it may happen so that measles even causes measles, whooping cough, they are known. That later on the child may recover, but suppose child was suffering from primary complex, and due to the immunosuppression due to this virus, measles, child can go for further flare-up of tuberculosis. Am I right? So you can take it, I will say, so try to explain in this way that what is the importance of fever and rash. That means no measles. Right, okay. I think in the exam, suppose somebody is asking, give a very good smart explanation, which is quite palatable. And examiner will 100% agree with you. That's a very good point. Right. So take in this way. Okay. Vishal, what is the importance of jaundice you mentioned?
Sir, for history of hepatitis recently.
Okay. In other way, how I will say smart you will explain. Suppose jaundice was there in the past. And now the patient is presented with distension of abdomen, gradually, progressively increasing. What does it indicate? Sagrika, any idea?
Sir, now the distension is due to ascites.
Yeah. Then what does it indicate? Jaundice in the past. Chronic liver disease. Chronic liver disease can present with this ascites and all disorders, may present with portal hypertension, may present with ascites, may present gradually with hepatic failure. So I think in our case, when we are discussing this distension of abdomen, we are probably excluding that it is not the complication in the form of the ascites due to the hepatic problem in the past. Right. So that becomes very palatable explanation. Very good. Go further. What is the convergence?
Sir, to rule out meningitis, sir, when maybe.
Okay, Vishal, meningitis and this present illness you will try to link. Is there any link? Is there any explanation, connection?
Sir,
past meningitis and the present illness?
Sir, TB meningitis is present, sir.
Okay. Now, on the contrary, tuberculosis meningitis, so I will say severe form of tuberculosis are present in the past. And suppose if it is treated, further there are less chances that the patient will come with the abdominal tuberculosis. Am I right? Because on the contrary, CNS tuberculosis will treat for longer time. So there is no chance that again the patient will go for this. Right. So again, what is my point? That put this exact particular point where you have the explanation. If you don't have, best way is to remain away, unless some examiner is asking. Okay. Take it further.
Sir, abdominal pain in case of acute gastroenteritis, sir.
Acute gastroenteritis for 6 weeks, because here history is of 6 weeks. I will take in some other way. So but the fever is not there. But abdominal pain is off and on, significant abdominal pain. And even distension of abdomen is gradually, progressively increasing. Even there is no ascites. But yes, some features of obstruction is there. And abdominal pain off and on, significant complaint, and of very long duration. And on examination, distension of abdomen, some features suggesting obstruction even. Anybody can explain what it could be?
Intussusception.
Intussusception of not the longer duration, Sagrika, it will be a few days. Acute history, you know, intussusception is an acute condition. Here it is a chronic condition I'm talking. Somebody has put the constipation, okay, constipation can come. But here, you know, if I give the idea, not uncommon, it is parasitological condition, which can cause the intestinal obstruction, mechanical intestinal obstruction. It is not toxic paralytic ileus. It is not due to the hypertrophy of intestine or anything else. It is not a peritonitis, but it is the mechanical. That means the presence of that parasite itself is responsible for the obstruction.
Lumbricoids.
And now which is, I think you should be able to answer.
Lumbricoids, sir.
Sorry?
Lumbricoids.
Lumbricoids. What is lumbricoids? Yes? Ascariasis, roundworms. Good. You know, ascariasis is known for all its complications. And it can come with this one obstruction. It reminds me almost more than 20 years back. Very classically, I said it's a likely ascites. I sent for the sonography. And then the radiologist called me that for what reason you have asked for this sonography. I said, I'm suspecting ascites. He said, there is no fluid in the peritoneal cavity, but plenty of the roundworms. He said, at least I'm able to count 150. Beyond that, I'm not able to count even. So, you know, roundworms are known to present. And they can present with the weight loss and all the features, even hypoproteinemia, all the complaints. So, you know, please keep in mind all the various explanations. Suppose if you're putting, okay, for micturition again.
UTI, sir. For UTI, sir.
UTI will present with the distension of abdomen of 1 month. Only fever, yes.
Fever, sir.
Only fever, yes. But when you put all the symptoms together, then probably many causes will go away. Anyway, please keep in mind.
No history of vomiting after several hours of food intake, sir. Maybe gastric outlet obstruction to rule out gastric outlet obstruction. No history of, sir, it's a mistake. There is no history of constipation to rule out the intestine obstruction or maybe thyroid. No, sir, it is mistake. No history of constipation.
No, I will say it is not mistake. It is most correct. I will say it is most correct point. But diarrhea is not acute diarrhea.
Yes, sir.
It's a chronic diarrhea. Then what it could be? Chronic diarrhea patient is presented with distension of abdomen and weight loss and not growing baby.
Celiac.
Yeah, celiac disease. Right. So probably you can say that the chronic diarrhea. History of edema over the face, and I will say as a whole edema, you can say. Right. So very good negative point. Again, if I remind you, please keep in mind when you are presenting the case, select the negative points which you have the explanation. It is, I will say, having the link with your case. I will say it is relevant to your presentation of the case. And relevance in the form of either strengthening your possibility, whichever you are considering, suppose tuberculosis, hepatic problem, celiac, whatever you are likely to you, related to that condition, find out the points, favoring and unfavoring, or nearby differential conditions. And third, complications related to your possibility. And if you put, I'm sure, the negative history, which will become the very short, sweet, and even you have the explanation for every point. Right. So I'm sure that you will keep in mind this point. But you have, I would say, put the good points or the negative. Please take it further.
In past history, there was no history of hospitalization in past. Family history, second by birth order, born of a non-consanguineous marriage. There was no TB contact on TB in family members, no history of thyroid disorder in family, no similar complaints in family member, no history of any liver disorder in the family.
Again, Vishal, if I remind you, and to all the students, put the relevant point, otherwise it becomes difficult. I think tuberculosis, yes, relevant point. But how the thyroid is relevant in this?
Sir, abdominal distensions are may be present in thyroid, sir.
Vishal, as a whole, you will have to see your case. It will not be presenting only distension. Here, the patient is having the fever
And fasting, weight
tension of
loss.
abdomen, even this vomiting, right? So all the points together. Similarly, I will say what other thing you have mentioned?
Weight
Anyway,
loss, sir. Weight loss, sir.
Anyway, what is my point? That find out this relevant point. Okay, no problem. Codes, go ahead.
Birth history, antenatal, uneventful, natal history, hospital delivered, full term, normal delivery, cried immediately after birth. Birth weight was 3.5 kg as per mother. Postnatal history, uneventful. Immunization history. The child was vaccinated till 1.5 years of age. The birth vaccine BCG, OPV 0 dose, hepatitis B 0 dose was given. At 1.5 months, Penta 1, FIPV 1, PCV 1, Rota 1, OPV 1. 2.5 months, Penta second, Rota second, OPV second. At 3.5 months, Penta third, FIPV second, PCV second, Rota 3, OPV 3. At 9 months, MR1, vitamin A. At 1.5 years of age, DPT booster, OPV booster, MR second, and vitamin A.
I think Vishal has put this history details nicely in the and this is important from the exam point of view. So please keep in mind and be prepared. What is the National Immunization Program? What recently some changes they have made? And if really this, I'm sure that what the Vishal has selected the case, Lunawada, and that to distant village from Lunawada. Lunawada is considered as little bit, I will say, underdeveloped area in Gujarat. And even the lesser the health facility, and at such a place, even suppose this type of the government services are available, I think that is also appreciable. That health workers are really working.
Very good point you have made, sir.
Sir, is it right?
Yeah, absolutely correct, sir. The remote area where this thing, vaccines are being given, that is a very encouraging trend.
Yeah. And sir, I know this area where this Lonawala he's saying, it's a I would say little bit underdeveloped, and even the lesser the facility, and this village, as he said, must be away from even that.
And people are also aware and taking it, in spite of availability. Sometimes it may be available, but they may have vaccine hesitancy, but they are accepting it and taking it is a very great thing.
Some I will say senior examiner or really those who are interested, like Srinivasan sir, they will draw our attention that this is a reflection of health services in our remote places. This is a reflection, just we don't know, right? Just as a part of our history, we have come to know that all these vaccines in a very small or remote place, it is provided, and that is a reflection. It's a part of reflection, may not be all the places, but yes, that means it's a good health services are there in our country and they are trying their best. Always, try to learn and try to appreciate that what the people are working. Which already we discussed that this in a very small village, the practitioner, even these, I will say, Anganwadi worker or health workers, those who are providing these immunization services, that means these are the points even which we will also note and learn that how they are doing. An exam point of view, I'm sure that these people may ask even this type of the questions which we should be prepared. The schedule changes, recent changes. What is this one very specific mission by the government of India?
So 9 months FIPV and PCV. Yes, sir. 9 months.
Sorry,
Mm,
your voice is not reaching properly, clearly.
uh, Sir, 9 months FIPV is added.
No,
for
no.
those-
What is the very specific mission? Immunization.
Indradhanush. Mission Indradhanush, sir.
Mission Indradhanush. Very good. Somebody will ask you this, what is this mission Indradhanush? What is it? Why specific name is given? And on which part the government wants to emphasize? Because sometimes what happens that you have prepared your MD examination for your very specific clinical case. But examiner wants that this country needs a basic pediatrician. So that good services should be available to even the remote places. And even should be aware of the government policies and government, I will say, whatever the programs are there. So that tomorrow as a pediatrician, you can implement it properly and you can contribute the health services of this country. The very senior pediatrician person who is having this vision, he wants to assess you in this way, that whether you are really competent enough as I will say, appropriate pediatrician, which this country needs. And I'm sure that if you are very competent, they will assess you as a whole, that if you know one syndrome or if you don't know another syndrome, probably it's not important. Syndromes may not be known to the examiners, or even I would say to any person, and probably it is not important also. But what is important, that the competent pediatrician should be at least competent enough to identify the problem of his country and how everybody is trying, whether the government health services or private health services, and with the full information and knowledge, how much you are prepared to tackle it. I think that should be even the motive of the examiner to assess the pediatrician, not to ask one or two just questions of your recent advices or some syndrome, right? So this is another thing which even I will draw your attention. And I think we should prepare in such a way, and sure examiner even assesses in this way. If you are knowing, he'll be impressed. Vishal, thank you very much. I think you have done the good job. Please take it further. I think Srinivasan sir will appreciate this, my point that, is it right, sir? Because I know Srinivasan sir, his main interest is nutrition and all these type of health services. Okay.
Yeah. That is, nutrition is very important for everybody.
Okay, Vishal, you can take it further.
Developmental history, sir. Gross motor, sir. Hops on 1 foot, alternate feet going downstairs, which is normal as for the age of the child. Copies plus and a tilted plus, which is normal for the age of the child. Language, repeat 3 numbers, sings poem. Social, knows age, sex, name, and right left side discrimination, which is normal. The child is developmentally normal.
Okay, please go to this previous slide. Yes, development. Another point which I have noted when you were talking, Vishal, that is, I will say for other students also, for the sake of exam. Older the child, we do not start from the head control and then the social smiles and like that. It becomes the, I will say, clumsy presentation. But suppose 4 years old child, very rightly he said that what is the expected in a 4 years old child? And suppose the child has achieved, at least it indicates that it is normal. That's all. And that is another way, support delayed development in another way, that what is expected for 4 years old child. If it is not there, that means it is abnormal. And then you can find out up to what age the child has received. Suppose 4 years old child, then you go back and you decide that, oh, it is up to the 2 years, whatever the child has achieved. So I think history taking, developmental history also should be impressive. We not try like undergraduate student that from the 3 months and 6 weeks and then 3 months and like that. Make it, I will say, very appropriate. I think very rightly he conveyed over here that what is expected from 4 years old child and what this child is able to do. And therefore my interpretation, the development is normal. That's fine. Good. Please go ahead.
Dietary history, energy, calorie intake was 610 kilocalories. Expected is 1,350, which is 55% deficit. Proteins 11.5 grams per day. Expected is 20.1 grams. So there is 43% of the deficit in protein intake. Summary: 45 months old female belonging to lower socioeconomic class, presenting with fevers of 1.5 months, abdominal distension with since 1 month, weight loss and vomiting since last 7 days. No history of hospitalization, no family history of liver disorder or chronic illness, no TB contact, uneventful birth history and normal neurodevelopment, immunized till 1.5 years of age, dietary deficit of 55% calorie and 43% of protein.
Okay, can you just stop sharing for a while? I think your history part is over.
Yes, sir.
I think many points we discuss in the flow, and I'm sure that most of the points are covered. Here now I want the summary. Vishal has given the summary in some other way, but I wish that we have discussed in the past also that from the history, the summary should be very small paragraph of about 8-10 lines, and that should contain, already every point it discussed at length. Now, how you are taking it, how you are interpreting it, what is your inference, that should be reflected in your summary, not the whole repetition of all the findings or all the points on the history. So who will take it? Hetvi, Chanmejay, please keep your video on. I hope that you are there. Monica.
So 4-year-old female child presented with complaint of abdominal distension, fever and vomiting with no significant past or family history. And on developmentally, the patient was normal according to the age.
Okay. Take it
And sir,
anyway, what is your interpretation? What does it indicate? What is the likely problem with the child?
so likely there is some chronic disease that affect the
Yes, go ahead. Chronic disease. What type of chronic disease?
so it can be a tuberculosis
Okay.
pointing towards the weight loss.
Okay.
And abdominal distension, weight loss and fever since 1.5 months. It can be a abdominal tuberculosis, sir.
Okay. Anything else? This is one point. Any other possibility?
Sir, other malignancy, sir.
Okay. What are the points favoring malignancy?
So weight loss,
Okay.
abdominal distension and fever, sir.
Okay. Commonly, suppose any malignant condition is since 1.5 months, what are the other expected problems besides fever, weight loss, and everything? Some hematological problems develop to the child commonly, and therefore how they present, at least anemia, toxic look, maybe even thrombocytopenia, and therefore some skin bleeding, some pitical spots or something, or joint pain. Maybe not necessarily every time, even just may come as a fever only. So, of course, I agree that it remains one of the possibilities. Anything else? Any other would like to make the attempt at how we will try to put the summary? Yes, Sagrika, would you like to?
Yes, sir. Sir, a 4-year female child with complaint of fever, weight loss, and abdominal distension with almost 1 to 1.5 months, with vomiting of 7 days. There is there can be a chronic pathology. It can be infective like tuberculosis. It can be infective like hidden abscesses or UTI or any enteric fever or malaria. In case of inflammatory, it can be Kawasaki disease. In case of malignancy can also be present, but malabsorptive disease like celiac disease can also be possibility.
Sagrika, Kawasaki disease, do anything manifestation for 6 weeks, like skin, red eyes, strawberry tongue, skin manifestations, exfoliations, right? On the contrary, something, these manifestations are common. Uncommonly, even it can present anything in the medicine. So I will try to, but I will say good attempt, good conditions you have considered in the differential diagnosis. I think simply how we can try it. Just let me one put at the end. I will also try how better I can do. I'm not sure. Sometimes it is possible that your presentation may be better than what I say. You know, we can make the statement in this way that 4-year-old child had presented with a, you know, try to keep in mind that first my point, anatomy, where is the likely problem? Second, my attempt will be what is the likely pathology? And in the pathology, etiology may not be possible in history most of the times, but possible etiology I can consider. Most common first and then the less common, according to the presentation. I think this point should be in your mind when you are presenting. Therefore, here you can say in this way that 4 years female child had presented with an illness of about 6 weeks or so, indicating it's a chronic problem. Mainly with the abdominal symptoms of distension of abdomen and vomiting, it is likely that the problem should be somewhere in the abdomen. And even the presence of fever, which has been documented high grade, it is infective. If I consider infective chronic disease involving abdomen with even significant weight loss, then the point becomes very clear that it should be infective or non-infective inflammatory condition involving the abdomen. Distension of abdomen again may be due to the common two presentations, either the organomegaly or the ascites. And this is very common in our country, even the enteric fever with the complications, but fortunately now complication rate in the enteric has come down. But tuberculosis can present in this way. There's therefore abdominal tuberculosis. Enteric with its complications, I can explain easily. Or even the celiac basically, and it has superseded some infection in the form of the enteric or some other condition. Even brucellosis also cannot be ruled out in such patients, therefore it remains one of the possibilities. Of course, if I don't get this infection, on further workup and even the investigations, I will have to keep in mind the connective tissue disorders and manifestation. I'm sure that if we commit in this way, it becomes short, small, and approaches. Always another thing which I remind you that when we are going for the summary, keep in mind where is the anatomy, which system is involved, which part of the system is involved, and then what type of disorder it is. Is it traumatic, inflammatory, neoplastic, degenerative, whatever it is. That type of the pathology. And then probably etiology may not be clear unless very few conditions. You can consider the common conditions first, then the less common and rare. That should be the order. And then you can say that on examination and further investigations, you can get more informations and you can focus. I'm sure that this type of presentation, if you say in the summary, even with a few sentences, there is no repeat to everything. Okay. I think, I hope that the good discussion we have done in the history part only for 1.5 hours. Wow, we have the
Yeah, we have to go to exam now.
Yes. Sir, is it right?
Very well discussed at length, so it's wonderful. So let us see, because half an hour they have to mention the clinical finding.
I think we have
We have covered almost all possible causes of such a thing.
Yeah. I think Dr. Deepa is also there. Deepa, your points, please. Anything which you would like to add or?
No, sir, you have almost summarized everything.
No. Because what is my idea, that more numbers of the teachers, some more comments from all of us, maybe some different even. Ultimately, all of us can learn, and even the students can learn more.
Yeah, you have to spread the net wide to catch something. So that's what, yeah. So we have almost encompassed every possible this thing.
Thank you, sir. I think Vishal, now we can go ahead. As sir said, we have only 30 minutes. But most of the clinicians say that if you have done the good history, examination is just for your confirmation that whatever you have thought of. So I think if you have done the good history, then on examination, you can confirm that what I'm expecting, whether they are there or not. So Vishal, you can go for the examination.
This is the photo of the child.
Vishal, you can at least describe that, what you want to show in this clinical photograph.
Sir, abdominal distension, sir. Firstly, then, sir, the rachitic rosary present in the chest, sir, over here.
Okay.
The child looks emaciated, sir.
I think what are all these threads?
So threads, sir, there.
Around the, I will say, upper extremities, even the chest and other places.
They are due to cultural beliefs, sir. They keep for.
But how you will try to translate that cultural things in our I would say interpretation of our.
First, the attitude of the child, sick looking or not sick looking.
Yeah.
Then you mention specifics. So study whether it's a sick looking child or ill looking child or not ill looking child. Okay, apathetic. Okay, and then you mention specifics as you have mentioned about the rachitic rosary, distension of abdomen, etc.
Sir, I think sir has brought out very, very important point.
Sir.
And I think, sir, we are missing every time, and sir brings this point. It's very important that always try to describe from the look of the appearance of the patient. And even general, I will say, your impression regarding the growth.
Yeah, of course, he has mentioned about emaciation, yeah.
And then you can go for other aspects, very specific clinical science, whatever you have. But always start in this way. I think, again, you can try. What will be your points for appearance?
So the child is active, playful, sir. On examination, the abdomen.
I think what is seen, just you can say what you are able to see from this photograph. Or I think when you have seen the patient, you can say that what was the appearance, whether the child was paying the attention when you were talking, whether the child was allowing you to examine, whether the child was playing, or whether the child didn't like to take the interest of the surroundings. I think all these points are very, very important.
Attitude of the child, general attitude, appearance, alertness, awakefulness.
So
the child was.
Points, please remember.
Yes, sir.
And this point is, I'm sure that if you speak in the exam from the beginning, it will be impressive, and it is considered as very essential. Okay. Anything else?
No, sir.
Okay, go ahead.
Child appears undernourished. Child was conscious, alert. Severe pallor present over palms and conjunctiva. No clubbing, cyanosis, jaundice or edema. No lymph nodes. No rash. Temperature was 102.7.
Is it undernourished, or you have seen the child for almost 4-year-old child, but you think looks like a 4-year-old child? You just mentioned undernourished. Is he severely malnourished or undernourished according to your appearance?
Sir, severely malnourished.
Yeah.
You know,
Yeah.
so
He looks
build a
almost
proper
like a
cardiology.
1.5-year-old child lying down. Yeah.
Temperature was 102.7 degrees by digital thermometer in right axilla. Pulse rate was 128 per minute in right radial artery. Good pulse volume, normal rhythm. Respiratory rate was 28 per minute. Regular thoracoabdominal type of respiration. Blood pressure was 96 by 58 mm of Hg, between 58 to 98 percentile, which is normal. Saturation was 98% on room air. Anthropometry, weight of the child was 9.2 kgs. Expected is 15.5 kg. With the inference is the weight is less than -3 standard deviation, which is severe underweight. Height of the child was 94 centimeter. Expected was 100.9. Inference is mild wasting. Mild stunting. Sorry. Weight for height is 9.2. Weight for height and expected is 13.6, which was less than -3, which suggests severe wasting. And medium circumference was 9 centimeters. So this child comes under severe acute malnutrition according to WHO. This is the growth chart of the child. The weight is over here less than -3. Height is somewhere between here -1 to -2 standard deviation, and weight for height is over here less than -3 standard deviation.
So what is your interpretation?
Sir, the child comes in severe acute malnutrition, sir, according to WHO classification.
Okay. And that's why sir said that in general impression that your undernourished is not the right.
He is correct. Height is not that much affected, but wasting
Weight is
there.
affected, sir.
Okay.
Head to toe examination. Head and face normal. Cachexic present. Eyes, conjunctiva paler present. Neck normal. Oral cavity normal. No ulcers. Tongue paler present. Upper limb normal. Palm severe paler present. Chest rachitic rosary present.
Head is very important. We are saying rachitic rosary, but
Yes.
the brain is head circumference is very important, because usually the head is enlarging very fast. So you'll find the caput quadratum. So you have to see whether the fontanelle is still open. Okay. So it's very important you mention about the skull and the appearance of the skull, because the first 4 years the rapidly growing circumference, head circumference. So they'll be able to find when you are finding rickety rosary, rickets changes will be there in the fontanelle also, whether the child is having frontal prominence. Am I correct, sir?
Yes, sir. Yes, sir. Sir, absolutely right. So keep in mind, and I think in this patient positively, we can mention the status of the entire control, even 4 years old child, looking at the nutrition of the child. Okay.
Abdomen distension present, skin normal, external genitalia normal, legs bowing up, legs present, decreased pad of fat in buttocks and muscle wasting presence. In this picture, there is bowing of the legs and abdominal distensions with emaciated look. And in this picture, sir, the decreased pad of fat in buttocks, sir.
The head looks very large because because of wasting. Head circumference is very important. Fontanelle you must see. You see the previous picture. Show the picture. See, the head seems to be very heavy when compared to that, and the head circumference seems to be quite this thing. Yeah, hair growth also is there, and the sparse hair is there. Some loss of hair also you can see.
A systemic examination. Abdominal system inspection, shape, localized distension present, abdominal movements, abdominothoracic type of respiration, no any scars on abdomen, obliquus everted, no visible superficial veins or abdomen, no visible pulsation or peristalsis, inguinal region normal, groin and anal opening normal, external genitalia normal. Superficial palpation, soft, non-tender. This is a mistake, sir. This is soft, non-tender, no guarding and rigidity, no abdominal wall edema. Deep palpation. On deep palpation, liver was palpable 5 centimeter below right costal margin in mid-clavicular line. Spleen was not palpable. Percussion, liver span was 10 centimeter. Auscultation, bowel sounds were normal.
Mentioned about the consistency of the liver on palpation. Those days, when we had internal cell cirrhosis, we had to tell exactly what type of liver and what is the border. Very, characteristic this thing will be there. So you have to mention what is the consistency of the liver. You have mentioned the enlargement, but palpation you have to tell this thing. Of course, now you have mentioned, yeah. Liver is palpable. Was it hard, cirrhotic like thing, or it is soft? Is it not important? Don't you think it's important?
Smooth, yes, sir.
Prajavati will be remembering our days when we had Indian cell cirrhosis. Commonly, you have to tell the border edge and
Yes, sir.
this thing,
Surface
yeah.
consistency.
And also the surface.
The liver of the surface was smooth, firm. The margins were rounded, and there was no tenderness. RS, CVS, and CNS normal examination. Investigations.
I think, can you just stop sharing for a minute? Examinations, sir, has brought out certain points. And please keep in mind, at one point, Vishal said that the child is cachexic. At another place, he said that the child is emaciated. So I think whenever we are using all these terminologies, we should know the exact meaning and use at a proper place. That is very, very important. What you mean by all this terminology?
Buccal part of it was maintained, that cheeks are looking full.
Yeah. Anybody? When you will use this emaciation, when you will say cachexia, and the interpretation, and even it conveys the very specific some conditions also. Somebody will ask in this way, what is the underweight, number one? What is the wasting? What is the stunting? What is the emaciation? And what is the cachexia? I think all this terminology, we should know the exact meaning and use appropriately in your patient.
The stunting is height is less than for the age.
Stunting is,
height is less than according to age, sir.
Okay, I think that's why I think we can use the stunting. And then what is the wasting?
So wasting is weight is less than
Weight is less for
age, sir.
Okay.
Sir, wasting means weight is less than for less according to height.
Yeah. Weight is less for that height. Right. Then we say wasting. And then what is emaciation? It's a general terminology, but I think with the reference to nutrition, we want to convey the exact message that what we mean by the emaciation. Vishal, any idea?
Sir, decreased fat and muscle mass, sir.
Good. When generally there is loss of the fat and muscle mass, we say emaciated. I think several times even routinely also you must have heard that some of your friends, when you meet even, you say that, oh, after a very long time you are meeting, but you are looking emaciated.
Below 5 years, head circumference is also important parameter to be mentioned.
It's very, very important. So emaciation, that means, classically, even in a case of marasmus, you can say emaciation. And what is the cachexia? Cachexia is a severe condition where only
bones.
skin and bones. And within the short time, sometimes cachexia develops. May not be common in children, common in adults. Sometimes it may be common chronic infections like tuberculosis, but more so common with the malignancy or even the hyperthyroidism like disease. So I think, once you say cachexic, that means within the very short time, the person has lost everything, fat and muscle mass, and just looking with the skin and skeleton. And that conveys the condition that more likely these type of the serious conditions, maybe some malignancy, hyperthyroidism, right? Or even chronic diseases like tuberculosis. And that's why we will use the very appropriate terminology when you want to convey. So please remember, I'm sure that if you are using this appropriate word, they will appreciate. Second, Sir Srinivasan sir has brought out a very important point, Sharon, for the exam also. Liver should be described very appropriately. I think in my book, Iap Clinical Examination, if you see, I have given one table that what are the points to be described for the liver. Number is size, particularly below right costal margin, at midclavicular line, then upper border and total span. Span is very important for the size, not just palpability on clinical examination. Then what is the consistency, whether it is soft, firm or hard. How will you decide that this is soft, firm and hard? Somebody will ask you one very simple basic question. How will you feel that this is soft, this is firm and hard? That means how will you compare? Is there any comparison in the clinical medicine? Where you can say this is the consistency of soft, this is the firm, this is the hard. Anybody have any idea? Hetvi? Or Vishal?
So form is like tip of the nose, sir.
Okay, and soft?
So
Starts, I would say, lower to nose.
lips, sir.
Lips. Lips are soft. Tip of nose is firm. And glabular area, that is hard. That is the body part. So how we can compare lips, soft, tip of the nose firm, and glabular area, that is the skull part, is the firm, hard in consistency. So like that. So size, then consistency, tender or non-tender, then the surface, even whether it is smooth or nodular in a case of cirrhosis of liver. Then what is this, even its margin, whether it is a rounded or sharp. So all the points, and interpretation of each finding, if somebody is asking, we should be aware of it. And that's why I think Sir has brought out very important point. And one more point, even for the exam point of view. Whatever the system, some upper GI tract or respiratory system, upper part of the system, don't miss it. Suppose GI tract starts from the oral cavity. That is oral cavity, particularly when you may get the pallor, you may get sometimes even the various colors of the tongue. Even you can see the palate or tonsils, particularly even the numbers of teeth. All the points should be there in a case of upper GI tract. And then come to this proper exam. Similarly for the respiratory system. So I think from exam point of view, these points are very important, which we should not miss. I think rest of the points, okay, what you have described. I think now whatever investigations we have, we can focus.
Investigations, CBC was done, hemoglobin was 6.7, total count was 12.8, differential 62, neutro 35, lympho, hematocrit 28.8, platelet was 441, ESR was 82, and Montauk test was positive. Hemoglobin less than 6 suggests severe anemia, and ESR suggests inflammation, sir.
Can you just stop sharing for a minute? Again, for the undergraduate students, these points are okay. But put your interpretation. I think hemoglobin 6.7, but what part is lacking over here, Vishal? Very important point in the
Units, sir. Gram per deciliter.
No, not the units I want to say. Part of the CBC. Peripheral smear examination is very, very important. Because with this hemoglobin 6.7, what is the morphology of the RBC? Whether the hypochromic, microcytic, macrocytic, whether suppose in a case of hemolysis, various abnormal RBCs, different stages of the maturity, reticulocyte count. These points are very important. That will give the idea that what type of the anemia it is and what is the likely cause for this. Even all the indices, its interpretation, right? So I think the investigation, and nowadays, fortunately, the MD examination, fortunately or unfortunately, there is no ASCII. But in the ASCII, many times they will put some findings and then interpret these findings. They may put this CBC and then peripheral smear or even some indices and then interpret it. So I think that part also, but I think that even in MD also, table viva, people are asking these type of questions. So we should
immediately after the physical examination, you have to mention malnutrition plus severe anemia, because we have seen severe anemia in the diagnosis.
Okay. Anything else? Investigations now, because we have to keep in time also. Anything else is there?
Sir, chest X-ray, sir.
Okay.
Just X-ray was normal, sir, and the liver is enlarged in the X-ray.
Is it normal? X-ray chest. Sagrika, what is your idea? Your interpretation?
Sir, definitely the liver is large, but the ribs are more flattened.
Okay. I think may not be convincing, obviously, but anything parametric here? If you see particularly on the right side, yeah, right, Vishal, yes, what is that structure? And if you come down again some power side.
Another important thing you have to mention is no rickety changes, either in the humerus,
here it is not
growing
seen.
end of the humerus, or in the costochondral beading is not there. X-ray also will show this thing.
Absolutely. Okay, anything else you have done?
Sir, USG was done. Suggesting of mild enlarged liver and increased echo pattern, and impression was mild hepatomegaly with grade 3 fatty changes, ileocecal junction thickening with retroperitoneal lymph nodes.
Okay. Can you just stop sharing? Sagrika, what the sonography has mentioned?
Sir, hepatomegaly with fatty changes and lymphadenopathy.
And one very important point, which we have taken in the discussion, we are not aware. What, Vishal, can you read without sharing?
Sir, ileocecal junction thick.
Yeah, that ileocecal junction thickening, what does it indicate? What is likely pathology?
Tuberculosis.
Likely pathology is tuberculosis. Certain points we'll have to try to find out. I think suppose if you have suspected tuberculosis, then last some of the points I will draw your attention from the exam point of view. If you have suspected tuberculosis in this patient, what investigations you will plan? Sagrika, would you like to answer? I'm sure that these are going to be the very common questions.
Firstly, chest X-ray, Bontox test, ESR,
Okay, number one.
and
Number
CBR.
one. In the chest X-ray, what are the findings highly suggesting tuberculosis? I'm not talking about this
Hilar
patient. I'm not talking about
lymphadenopathy.
this patient. In any patient, which are the chest findings, which you will say that this is the highly suggesting tuberculosis?
Sir, perihilar lymphadenopathy.
Okay. Anything else?
Sir, miliary pattern.
Very good. One is biliary pattern. Anything else? Please remember that is the as per the latest RNTPC. Now we say the National Tuberculosis Elimination Program. And in that case, others are non-specific. We may not give the much importance for tuberculosis. But in the chest X-ray, if you get the paratracheal glands, rather than hilar, even the paratracheal glands, that is more suggesting tuberculosis. Biliary shadows give the importance that suggesting tuberculosis. And fibrocavitary lesion, cavity, fibrocavitary lesions in the X-ray. These are the only three important points to consider in chest X-ray, highly suggesting tuberculosis. Okay, so I think number one, you will go for the chest X-ray. Mentu test, Vishal, by which tuberculin fluid you have done this Mentu test? But ideally, which fluid should be used? What strength and everything?
Purified protein derivatives, sir.
Okay, what strength, Hetvi?
1/40.
You must be knowing tuberculin in it. Which TU?
0.1, sir.
At least 1 TU, maximum 2 TU. Don't use this beyond 2 TU, because if you use beyond 2 TU, then Mentu test positive maybe due to the greater strength of the tuberculin protein. Again, Mentu test positive, what is the importance? Sagrika, how much importance you will give for the Mentu test positive?
Sir, it means a patient can have active or past infection or can have post-vaccination.
Okay.
Positive.
Simply answer one line. Positive Mentu test indicates that the child is exposed to the bacilli, not necessarily disease. In other way, it indicates infection. Disease may be there, but from the positive Mentu test, your inference should not be the disease. That's very important point. One more point, sometimes people may ask, what would be the reading which you will consider as a positive Mentu test? Size of the positive, I will say reading. What size of this lesion? Inflammation, you will consider the positive?
More than 10 millimeter.
Okay, more than 10 millimeter in which direction?
Sir, in the vertical, maximum
horizontal. It is only, many times we mention 10 by 12, 10 by 15 is not the right way. It is 10 or 15 millimeter. That should be measured in a horizontal direction, because that is the direction of the lymphatics. That's why it should be measured in that, and it should be measured with this plastic ruler. Sometimes in the instrument, somebody may keep it. So just for the exam point of view, you should know all this point. Anyway, so chest X-ray, Mentu test. But nowadays, molecular diagnosis is very important to liberate the tuberculosis. Before starting the anti-tubercular drugs, we are not allowed to start from the chest X-ray or Mentu test. So what are the molecular diagnostic tests, Sagrika, you will try or you will perform?
Sir, CBNet.
Sorry?
Sir, CBNet.
Okay. But which specimen you will use?
Sir, in case of pulmonary, we use the sputum or induced sputum or gastric aspirate.
Can you just clarify in which particular age group children all the different samples you will collect, where the gastric aspirate, where this sputum, in which child induced sputum?
Sir, in older child more than 5 years, patient can give a sputum.
Stool is very important nowadays. Stool. The face
Yeah.
is also very important nowadays. A lot of studies are coming.
Studies are coming up. I think in the future it may be there. But sir is just pointing out. But at present, what you said is right, that the older child, if the sputum is available, but the expectoration will be usually after 3 to 4 years. Therefore, sputum may not be possible younger the children. That's right. Suppose if the sputum is not possible, 2-3 years old child, what you will do?
Sir, induced sputum.
Induced sputum or something else.
Aspirate.
Child is 2 years old. So child is not able to give the sputum.
Gastric aspirate.
Yeah, because child is swallowing. And therefore gastric aspirate. Right, older the child sputum. When you will go for the induced sputum, sputum is not productive, not available. But still tuberculosis is possible. Then induce the sputum by bronchodilators and the saline, and whatever the material is available, send for the examination. So I think this is number one. Then what are the tests you will do? Suppose this sample material is available.
Sir, we can directly do the microscopy, or we can go for a nucleic acid amplification test.
Yeah. Always ZN stain is must. Even gram stain you can do, because maybe some other bacterial infection. And even CBNet is very important test. That is the nuclear acid amplification test, cartridge-based nuclear amplification test. And here it's a DNA of the material of the organism is identified. Somebody may ask the details. I may not go into details at present, but please read it. That is how the test is done. And then what is the turnaround time? That means within how much time this investigation is possible to do. And then what are the chances of getting the positive, the different samples? Please remember, in the particular histopathomaterial tissue, it is more chances of getting the positive. Then the CSF, then the sputum and gastric aspirate. Less positive CBNet in pleural ascitic fluid. Percentage I don't remember. You can check the percentage are also given. What is this ultra CBNet? Any idea? So I think with the lack of time, I may not go into details, but just I will draw attention. Read the CBNet. What is the ultra CBNet? What is the true net? And what is the WHO recognized rapid diagnostic test for the tuberculosis? Under this, all these tests comes, even line probe assay, one is the LAMP. And recent test even is not there in our WHO, I would say, recommendation, but in the practice it is that, what is the pyrosequencing? Pyrosequencing, even the minimum DNA material can be tested for sensitivity to the various drugs. And these are the molecular tests which we should know. For culture, MGIT, that is the recent, I will say, liquid tissue culture that we should know. The solid tissue culture, what we were doing, LG medium, is now not much recommended or in use. Then we should know particularly even investigations for CNS tuberculosis, for the ascitic fluid, for the tissue, histopathology, biopsy, everything. You know the drugs for the tuberculosis is totally changed, doses. Doses is higher, so that we should check. Steroids indications are very specific. And now vitamin B6, that is recommended in all the patients with the increasing dose of the INH, malnutrition, other aspects. INH prophylaxis dose we should know, which is 10 milligram per kg for 6 months and not the combination. And I think various aspects of tuberculosis with the pulmonary tuberculosis positive mother and the newborn, regarding breastfeeding, regarding vaccines, regarding prophylaxis, people are going to ask you. Regarding hepatotoxic drugs, the child develop this, then how will you define? SGPT more than 5 times without symptoms, or with symptoms more than 3 times SGPT raise? Consider this is the liver injury due to drugs, and then management is different. Then later on, people may ask regarding the even CTAB. CTAB is just like meant to test or interpreted. It has not come in our country, probably recent future it should come. That is for latent tuberculosis. The advancement somebody may ask. In tuberculosis, another thing people may ask regarding the paradoxical phenomena. And MDR tuberculosis. I think now MDR tuberculosis is also a very important question for the exam, because it is increasing in pediatrics, that we should know. I think many more things are there, but at some other time we'll take. This is just to sensitize you, all of you, from the exam point of view. And please read this recent, because it is changing very fast, National Tuberculosis Elimination Program. Anyway, we'll have to end over here. Srinivasa sir, anything, or because now we have overshooted the time also. So, Vishal, I think your selection of case was really good. In the exam, suppose such case is there, any exam there is going to keep this case. Very good from the nutrition, from the ascites, from distension, so many things. And I think we can discuss very appropriately if you are well prepared. So your selection of case was really good. Of course, it is not totally work up and confirm the diagnosis due to probably yes, your limitations, but certainly even in an exam also without workup, they are going to keep. And of course, all other students, I would say this time, many students were responding.
X-ray wrist was taken for any cupping or fraying because ribs didn't show evidence of rickets.
Yeah, it was there. I think, Vishal, you can check this. As sir said, is right.
Yeah.
And I think it seemed that Sagarika is well prepared for the exam. Very good. And I think I even request all other students that come with the preparations, interactive one, and definitely it makes difference in our learning and understanding, not only for exam, even for the good practice also. Thank you very much.
What is the definitive diagnosis, sir? Any specifically they have found out TB etiology?
Sure.
TB
No,
etiology
sir.
has been confirmed.
No, sir.
No, sir, it is not confirmed.
No, sir.
Because, you know, there is evidence of lymph nodes in the iliac fossa you mentioned. And then this thing, you know, yeah. Okay, thank you.
Thank you very much to all of you. And even the Dr. Deepa, madam, she just, I think, left a few minutes back only due to some other commitment. But I'm sure that even the involvement of more teachers will also the good learning for all of us. Thank you very much. I think Shweta is constantly helping us and requesting us to put the name.
We must thank her and good night to all of you. Yeah.
And even our president, Dr. Upendra and Dr. Vinit Saxena, they are very generous to provide us this platform. Thank you very much. Good night. Next Tuesday at 6 o'clock again, we'll be there with some new case. Take care and come with a good preparation. Thank
Good
you.
night. Thank you, all of you.
Thank you, sir.
Thank you, sir. Thank you very much.